Hi there, my name's Dr. Craig Rogers and I've been working in HIV now for almost 17 years. And today I'm here to talk to you about some health issues that are affecting HIV positive people at the moment. It's part of a campaign organised by AFAO, the Australian Federation of AIDS Organisation, known as Your Body Blueprint. And today I'll be taking you through various components of the website, particularly focusing on some of the major health issues affecting HIV positive people today. So we know with the availability of more effective HIV treatment regimens that people with HIV have a much greater life expectancy, which is fantastic. HIV we now consider as a chronic treatable condition, not unlike things like diabetes and epilepsy. However, people with HIV are now being exposed to conditions that also affect HIV negative people, such as heart disease, diabetes, issues with decreased bone mass. Some of you may have been diagnosed with HIV for a while and feel up to speed with some of these issues. But regardless of how old you are or how long you've been diagnosed, I'm going to be covering some of these issues today that will affect all HIV positive people and some of the key things that you can do to manage these issues and take control of your own health. So the treatment for HIV these days doesn't just concentrate on managing the virus itself, but it does take into account these other conditions that influence your long-term health. Often these are known as comorbidities, having two or several other conditions in addition to HIV. In particular, we need to place emphasis on the following conditions, and these will be the conditions I'll talk about today. So the heart, kidneys, liver, bones, issues around mental health and the brain, the immune system, and briefly touching on some cancers that are associated with HIV. So first up, we're going to talk about heart health. So the conditions that affect the heart and blood vessels are generally known as cardiovascular disease, or you may see the acronym CVD, cardiovascular disease. These include particularly things such as high blood pressure, which we call hypertension. Other issues are things like angina or heart attacks. Angina is like the precursor to a heart attack, and these generally occur when the arteries that supply the heart muscle, known as coronary arteries, become narrow or blocked. Other conditions that are often related to cardiovascular disease are things like strokes, which are known as cerebrovascular disease, and these are generally due to either blocked blood vessels in what we call the carotid arteries, or blocked blood vessels, or bleeds in the brain. Another related condition is something called peripheral vascular disease, and these generally relate to blocked blood vessels in the legs or the periphery, further away from the body. I guess I'd like to stress at this point that the heart health is one of the most important conditions that we face in dealing with HIV today, so there's a little bit more emphasis on this condition. In general, the risk factors for cardiovascular disease are things such as smoking, being overweight, being male, and being a male greater than 45, females over the age of 55, and particularly once females in menopause. High cholesterol and triglycerides, and these are known as fats, or also known as lipids, and we measure these in the blood. And also high blood sugar. There's a number of conditions that are related to high blood sugar, which you may or may not have heard of. Insulin resistance being one of the first conditions. That then can lead to things such as impaired glucose tolerance, and then ultimately diabetes. And we'll cover a little bit more of these in more detail through the presentation. In particular with people living with HIV and heart health, people with HIV unfortunately have a 1.5 to 2 times greater risk of developing coronary artery disease, so greater risk of developing or having a heart attack. And this is similar to the increased risk of cardiovascular disease that's attributable to smoking. So if you're HIV positive and smoking, then your cardiovascular risk is increased further. And again, as I explained, the greater risk in people with HIV in addition, is also greater than 45 years of age. What is also happening, though, is that people with HIV are developing cardiovascular disease at much younger ages than the HIV-negative population. And unfortunately, when we treat those narrow arteries, we do that with a procedure that's called angioplasty, which is opening up the blood vessels to the heart. And sometimes they put in something that's called a stent to keep that open. But unfortunately, there are higher rates of recurrence of cardiovascular disease once people have been treated with angioplasty. There's a number of mechanisms in which we believe that HIV contributes to increased risk of cardiovascular disease. One of them is that HIV in itself results in a process of what we call chronic inflammation in the body, and this chronic inflammation can lead to disease in the arteries, so narrowing or thickening of the arteries. Or we say that people living with HIV they live in a state of constant immune activation, and this immune activation contributes to changes in blood sugar levels and fats in the body as well. So a couple of reasons that HIV increases cardiovascular disease. If we do get changes in blood sugars and fats, these can actually sort of result in the development of blood clots in the arteries, particularly high cholesterol. It deposits in the arteries, narrows those arteries, and then leads to increased cardiovascular disease. We've also been aware that certain HIV treatments affect blood sugar levels and fat levels in the blood. In the earlier days, particularly protease inhibitors were attributed to causing this. Less so these days, but we still are concerned about HIV treatments potentially leading to increased risks of cardiovascular disease. So smoking, I guess I can't sort of stress how important this is to address. As I noted before, that cardiovascular risks are increased in people who smoke in general, also increased in people who are HIV positive and smoking. What we do see is that people with HIV generally are higher smokers in general, so at least 2 to 3 times greater than the HIV negative population, with about 50 to 70% of people with HIV positive, who are HIV positive smoking. And HIV positive smokers die at younger ages than HIV positive people that don't smoke. So it's very important that we address smoking in our HIV positive patients as well as our HIV negative patients. So what do we do to try and monitor the risks for cardiovascular disease? So I'm just going to talk about some of the things that your doctor will monitor or measure. And hopefully they do this on a regular basis, at least annually is what's recommended. So we measure your height and weight to determine something called your body mass index, or BMI. And the BMI is a way of us trying to sort of see if you're an appropriate weight for your height. It's not always accurate. The normal body mass index is between 19 to 25, and so if you're under 19, then generally that means you're underweight. If you're over 25, that means you're overweight. If you're over 30, that can indicate that you might be obese. However, it does it is influenced by certain races as well as muscle mass. So another measurement that we should also use is the waist circumference. Generally this is less than 94 centimetres in men and less than 80 centimetres, in females. The other thing that your doctor should check regularly is your blood pressure, as high levels of blood pressure contribute to cardiovascular disease. Normally, blood pressure is expressed as 2 readings. We call it a top reading and a bottom reading. So normal blood pressure we describe as 120 over 80. The top reading is known as a systolic blood pressure, and the bottom reading is known as your diastolic blood pressure. They sort of indicate different levels of heart function and the sort of relaxation of the arteries. So while normal blood pressure is 120 over 80, we can tolerate up to about 135 over 85, maybe 140 over 90 at a stretch. But your doctor will generally get concerned if it's above those measurements. Some of the blood tests that we recommend on a regular basis as well, generally annually or maybe more frequently if they're elevated, are fasting blood sugar level, known as a BSL, fasting cholesterol. There's two components to cholesterol, LDL and HDL, and I'll talk about those in the next slide. And also fasting triglycerides. I know I've said fasting 3 times there, but I do want people to understand that generally we have to measure these in a fasted state, and generally that means fasting for about 12 hours before they're collected. So what we often recommend is that people don't eat or drink anything after dinner, and then come in first thing in the morning to have their blood collected. And generally you can have water, and actually having water is a good idea. We don't want you to be dehydrated. You can brush your teeth and you can take your medications, but just don't have anything that has milk or sugar in it. That just gives us a better reading of these blood tests. So as I said, cholesterol and triglycerides are the 2 types of fat that are found in the body, or lipids. The different types of cholesterol I've spelled out here a little bit in more detail. So low density lipoprotein, or LDL, and this is known as the bad cholesterol. And it adds to sort of build up of plaque in the arteries. And the good cholesterol is your HDL cholesterol, or high density lipoprotein. And we need a certain amount of cholesterol to help build cell walls in the body. And it's protective against cardiovascular disease. So your doctor will talk to you about trying to lower your LDLs and trying to increase your HDLs. And they'll generally talk to you about increasing food rich in omega-3 amino acids, and particularly things like oily fish, salmon, tuna, those sorts of things, or taking a supplement, a fish oil supplement. And that will help increase your HDL and lower your triglycerides. They'll also talk about different levels of cholesterol. So in the general population, we aim for 1 level, but if you have existing cardiovascular disease, we might need to be more aggressive in terms of trying to lower your cholesterol to more, I guess, sort of stricter levels. Often though, we try a stepwise approach to treating high cholesterol, so we may not necessarily put you on medication straight away, and generally we'll try and sort of look at lifestyle interventions such as diet and exercise. If people are taking HIV treatments that may be related to higher lipid levels, then depending on your treatment history, we may be able to change the HIV regimen, and particularly today with some of the newer medications coming out, they're much more forgiving in terms of increasing lipid levels. So talking to your doctor about perhaps changing regimens may be feasible. And then if all else fails, then we will talk to you about medications to help lower cholesterol. Generally these are known as statins. There are other medications that act on cholesterol as well, but the common ones are statins. And we do have to be careful about which statins we use, because some of them do actually interact with HIV medications. So it's important that your doctor know what your HIV regimen is and which statin that they can use. Smoking again, what can you do? So stopping smoking is probably one of the most important things that you could do for your heart. Generally I don't use exclamation points in talks, but I do for this point. In addition to diet, regular exercise, and we generally recommend about 30 minutes a day of some form of slightly vigorous exercise. One thing that you might be able to do is either walk to work or walk home, using, I guess, some exercise clothes rather than your work clothes. This is sort of one way to just try and sort of structure a bit of exercise into your daily routine. Also, diet high in fruit, at least 2 pieces of fruit a day, vegetables, up to 5 serves per day, lean meats, such as fish, chicken, pork, as opposed to red meats, and a diet high in whole grain food. A lot of HIV services and GPs will have dietitians attached to their clinics, and we generally recommend people having a consultation with a dietitian to try and help talk them through some of the finer aspects of their diet. Also, we recommend avoiding foods high in sugar, particularly from the point of view of diabetes. foods known or containing saturated fat. So we have saturated fat, monounsaturated fat, polyunsaturated fat, etc. Saturated fat is the one that's bad for you, and this is particularly in certain meats, such as processed meats, sausages, salami, unfortunately not very good for you, and dairy products, particularly butter, cheese. Sadly, nobody seems to want to give those up, but it's a good idea to have a chat to your doctor about how you should limit those products. And salt as well. Higher salt intake will contribute to higher blood pressure, so it's a good idea to try and limit this if you can. In particularly, not adding salt to your food. Most food does have salt, but one of the first steps is to try and stop yourself from adding too much salt to your food. Also, we recommend safer levels of alcohol intake, and in the last couple of years, the body that oversees the alcohol intake guidelines, called the NHMRC, developed fairly strict guidelines in terms of recommending only 2 standard drinks per day. So rather than having alcohol-free days, which was initially recommended, the body has stated that 2 standard drinks a day is safe for everyone, men and women. So use that as a guide in terms of measuring your alcohol intake. And do remember that the standard drink is actually probably not the glass that you might pour at home, but generally a middy of beer, 100 mils of wine, which is generally less than what you may get in a restaurant, and 30 mils of spirits. Also important that you have regular monitoring tests of your cholesterol and blood sugar level, and monitor which treatments that you're on with your doctor. So now I'm going to talk about kidney health. So the kidneys act as one of the filtering systems in the body. It's probably the easiest way to describe it. But conditions such as diabetes, which is high blood sugar, and high blood pressure can also affect the kidneys, and particularly in HIV. And conversely, problems with the kidneys may also affect blood pressure, so it's often a little bit difficult to know which has come first. The way that we measure kidney function is generally through blood tests, particularly something known as creatinine, or another test known as estimated glomerular filtration rate, EGFR. And generally that's why your doctor will probably ask you to do a urine test every time they do bloods. And within the blood test we also monitor different parts of kidney function. Medically, the kidneys are known as the renal system, so you may hear your doctor talking about that as well. HIV, though, even without treatment, may lead to kidney disease, and certain populations particularly develop something called HIV-associated nephropathy, or HIVAN, and that's the kidney disease that is often associated with HIV. More recently, though, I guess in the last 10 years, we're particularly aware of certain HIV medications leading to short-term or long-term problems with the kidneys. And this is especially related to medications containing tenofovir, which a lot of people are taking. Tenofovir forms part of many of the combined HIV medications, so Truvada, Atripla, Eviplera and Stribald all contain tenofovir, so it's important that your doctor measure your kidney function if you're taking one of these medications. In the pipeline is a newer form of tenofovir that hopefully will have less side effects in terms of the kidneys, but unfortunately that's not available at the moment. In terms of the kidneys, as I said, diabetes can affect the kidneys. Diabetes generally is a condition that, as I said before, is due to high blood sugar level. Another term that we use is glucose. So your doctor may talk about glucose, blood sugar level, BSL. So we need glucose for fuel or energy. Without it, we can sort of feel very tired, lethargic, or grumpy. The levels of sugar or glucose in the blood are controlled by a hormone that's released from an organ in the body, sits around here, called the pancreas. This hormone is known as insulin. So you may have heard of insulin-dependent diabetics or non-insulin-dependent diabetics. If the process of either how insulin is released or how our body uses insulin is affected, then this can lead to high blood sugar levels. These conditions include so-called pre-diabetic conditions, insulin resistance being one of those. More commonly, people may be diagnosed with something called impaired glucose tolerance. So your blood sugar levels are a little bit high, but not high enough to say that you have diabetes. Diabetes being the next condition. Unfortunately, diabetes is also more common in people with HIV, about 4 times more common actually than the general population. And as mentioned in some of the other slides, the development of diabetes is associated with increased heart disease or cardiovascular disease. And some of the HIV treatments, particularly protease inhibitors, have been known to have an effect on insulin resistance. What can you do in terms of diabetes and your kidneys? It's very important to have your blood sugars and blood pressure monitored regularly. As I said, the blood sugars should be done fasting. Blood pressure can be done at any time. If people do have diabetes, there are certain health issues that are associated with that, such as chronic diabetes can affect your eyes, your feet, kidney function and diet. So if you have been diagnosed with impaired glucose tolerance or diabetes, your doctor may suggest that you have your eyes checked for changes behind the eye on the retina, or they may do a little nerve test of the feet. The conditions that can develop in the feet is something called peripheral neuropathy or problems with circulation. So checking that your feet are nice and warm with good pulses is important, and checking the sensation is important. Again, in terms of what we recommend in order to assist with the treatment of diabetes, regular exercise, healthy weight and diet. What your doctor might talk about in terms of diet is something called a low GI diet. A GI refers to something called glycemic index. I'm not going to talk a lot about glycemic index because it's a little bit confusing, but it's basically a measurement of the amount of carbohydrate or fuel that is in our diet. And it's usually on a scale of 0 to 100. So you might see this on the side of foods. Generally anything with a glycemic index of 55 or less are better for you. The sugar is more slowly digested, so much better if you have problems with your blood sugar level. Again, discuss your HIV treatments to see if they may be affecting your blood sugar level. Similarly to treating high cholesterol, we have medications that we use to treat blood sugar, and it doesn't necessarily mean that you'll need insulin. We generally start with diet management, followed by some of the tablets to help your body manage insulin. If all that does fail though, you may need to be on an insulin regimen, but generally the diabetes that develops later in life doesn't require insulin until later stages, hopefully. If people develop diabetes earlier in their life, they generally need insulin because their body's not producing it. As people get older, they just don't use insulin as effectively, so they may need a bit of help with low GI diets and medication. So now I'm going to talk a little bit about the liver. So the liver, I guess, is one of the most important organs in the body. A little bit like the kidneys, in that they sort of filter or process certain medications. The kidneys filter the blood, the liver sort of processes things like drugs, medications, etc. So it plays a key role in what we call the metabolism of medications and other drugs, including alcohol. So higher levels of alcohol do lead to significant liver disease. If the liver becomes inflamed, it's known as hepatitis, and a number of conditions called hepatitis. So it can be drugs, it can be alcohol, it can be viruses, such as hepatitis A, B and C, or other viruses, even something like glandular fever, or HIV itself sometimes causes a mild hepatitis. With hepatitis, if it becomes chronic or long-standing, then it can lead to a condition known as fibrosis, and this is scarring of the liver. If there's too much fibrosis in the liver, or too much scarring, then you can develop a condition that's known as cirrhosis. That's severe scarring of the liver. The problem with cirrhosis is, one, your liver doesn't work as well, but two, you may develop liver cancer, which we would rather avoid if possible. Liver disease, unfortunately, is one of the most frequent causes of what we call non-AIDS related deaths in people living with HIV. And the major factor for this is being co-infected with either hepatitis B or hepatitis C. Other issues, as I said, that can lead to hepatitis, alcohol consumption, obesity, high blood sugar levels, and high fats and cholesterol, and certainly some drugs that may damage the liver. And some HIV drugs in the past have been known to damage the liver quite severely. So it's very important that we measure liver function tests on a regular basis. Some herbal medications may also cause elevation of liver function. So it's important to tell your doctor what other medications you may be taking, whether they be over the counter or supplements, because they may be interacting with your HIV medications and or causing problems in the liver. So what can you do to assist with management of your liver health? Ask your doctor, or hopefully they should be doing this, is to test for the common viruses of hepatitis A, B and C. And if negative for these, then consider vaccination. We only have vaccination for hepatitis A and B. We don't have a vaccination for hepatitis C at this point. Hepatitis C is particularly an issue for people who inject drugs, as it's mainly transmitted through blood. There are some concerns that it may be transmitted through sexual contact, but it's really mainly through blood transmission. So particularly people who inject drugs and HIV positive gay men are at particular risk for hepatitis C. So it should be tested on a regular basis. What we do measure are something called liver function tests, or LFTs. We generally recommend having these tested before HIV treatment and every 3 to 4 months when people are on treatment. Again, a little bit like smoking, we recommend avoiding excess alcohol and trying to stick to no more than 2 standard drinks per day. As well as healthy diet and avoiding fatty foods. Too much fat in the diet, which, as I said, can build up in the arteries, may also build up in the liver, and some people develop a condition known as fatty liver, which is often demonstrated on an ultrasound. In terms of avoiding hepatitis B, and particularly in addition hepatitis C, we recommend safer sex, such as using a condom, and safer injecting practices, not sharing any needles and syringes or other injecting equipment. We're now going to talk a little bit about bone health. Bone disorders, there's a couple, osteopenia and osteoporosis, and both of these do occur at higher frequency in people living with HIV. Osteopenia, it's a little bit like the precursor to osteoporosis, and it's a mild decrease in the density of the bones, bone mineral density, or BMD is what you might sort of see written down. This may lead to a more serious condition known as osteoporosis, and this is a more severe decrease in bone mineral density. The way that we measure bone mineral density is by a test known as a DEXA scan, the technical term being dual energy X-ray absorptiometry. Some of the general risk factors for osteoporosis are increasing age, being female, a positive family history of somebody having osteoporosis, vitamin D deficiency, smoking again, and alcohol intake again, and steroid exposure. And this is generally what we call corticosteroids or medical steroids. With starting HIV treatments, we know that unfortunately there is a decrease in bone mineral density in the first 2 years. A small decrease, about a 2 to 6% decrease. And tenofovir again has been strongly associated with an acute decrease in bone mineral density. This decrease is similar to what happens in postmenopausal women. We know that after menopause, women are at increased risk of osteopenia and osteoporosis. And often it may be considered that they have treatment for these conditions. However, we tend to not avoid using tenofovir because of this decrease. It's something that we would monitor, as the use of tenofovir outweighs the risks of osteoporosis in this setting. We also know that if people have with HIV and not on treatment, they also do have an increased fracture risk compared to the HIV negative population. So we do still recommend treatment for people to avoid fracture, despite, I guess, the small risk of decreased bone mineral density. But particularly if you have some of those other risk factors, we may be more, I guess, aggressive or in terms of investigating bone mineral density. So how can you avoid developing osteoporosis? I can't believe I haven't put stopping smoking in here again. Maybe it'll come up in another slide. But what we need in our diet is calcium. And we need about 1,000 to 1,500 milligrams per day, depending on your level of osteoporosis. Particularly foods like milk and cheese are good. Milk and yogurt. Cheese would be good, but we have to be careful about the fat in cheese. But generally, 1 to 2 cups of milk per day, maybe 1 tub of yogurt per day would be a way of trying to increase calcium in your diet. Vitamin D is something that we've become a bit more concerned about in the last few years in HIV-positive people as well as the general population. We've been so good at avoiding the sun that we're actually causing low vitamin D levels. So it is recommended now that we try to get a little bit of sun on our bodies while still being sun smart. And there are guidelines around how much sun exposure you should have, particularly on the Body Blueprint site. You'll be able to access that there. If people are unable to get that sun exposure, then we may recommend supplements for that as well. There are also benefits in terms of exercise, again. Maybe not so much in terms of your cardiovascular health, but at least 3 days per week of about 30 minutes of weight-bearing exercise to help increase bone formation. There we are. What else can you do? Stopping smoking, limiting alcohol intake. We may recommend hormone replacement therapy in postmenopausal women. And tests that we may do are measuring your calcium levels and vitamin D levels in blood tests, or we may organise a DEXA scan if we have concerns. Moving on to mental health. And this, I'm going to cover issues associated with the brain. We know that the HIV virus does cross what we call the blood-brain barrier in the brain and infects brain cells. And now this can lead to changes in thinking and memory. We also know over the years that long-term HIV infection, generally untreated, may result in dementia. But luckily, this is now rare in Australia with newer HIV therapies. However, we do see subtle changes in thinking or cognitive functioning, and this is generally known as a condition called HAND, or HIV-associated neurocognitive decline. Slightly hard to detect, but if you feel that you're having any issues with your memory or concentration or attention, then important to talk to your doctor. They may be able to organise some baseline neurological tests. In particular, something called a neuropsychological test, which is quite involved, but it does sort of determine sort of higher levels of brain function. There are certain short surveys that the doctor may be able to conduct to measure your mental functioning, and other investigations such as CT scans or MRIs may be able to develop any changes in the brain structure. There are certain HIV treatments that we believe cross the blood-brain barrier better than other medications. So your doctor may consider adding these medications to your current regimen or changing your current regimen. But it's still a little bit undecided as to whether everybody should be on these better medications at this point in time, and I guess we'd prefer people to be taking any HIV medication rather than some of these extra ones which may increase the pill burden and therefore people don't take them. So I think your doctor might start on a more simple regimen, and if these conditions occur, may add to those regimens. HIV as a chronic medical condition can also have profound effects on people's mental health, and I've found over the years that HIV affects everybody differently. Depression and anxiety are generally experienced more commonly by people living with HIV. So it's important that you have a good network of friends and family around you if possible. If you don't, then I guess it's a good idea to maybe sort of access other support organisations to sort of assist with staying connected, and they may be able to assist you in terms of, I guess, staying social, getting out and about, maybe sort of talking to other people living with HIV helps certain people. The other thing that's often recommended, if possible, is exercise. It can really make a big difference to how you cope with things. It's very good at helping to relieve stress if possible, and as I sort of say to a lot of patients, it doesn't have to be vigorous exercise, just getting out and going for a walk to sort of clear the head. As I mentioned, contact with other positive people who can share your experience may be useful. It doesn't work for everybody, but often people may feel very isolated living with their infection, so it can be helpful to talk to other positive people. Organisations often have a list of workshops or social events for positive people, and some of this can be done online now, which is great for people who may not feel comfortable about mixing in a group setting. Your GP can also help, obviously, with these conditions. It doesn't necessarily mean that everyone will be referred to a psychiatrist. What they might suggest, though, is being referred to a counsellor, either social workers or psychologists, other types of counsellors, to discuss your issues. Depending on the type of counsellor, some of these sessions are covered under Medicare by something called a mental health plan. So generally have a chat to your doctor about this. It's generally a longer consultation that they need to write a referral for these. And you get up to 10 sessions per calendar year covered by Medicare for these sessions. And you may not need all 10, but it can be very useful to speak to somebody else, a professional, about how to deal with anxiety and depression and other mental health issues. The immune system. So HIV affects the immune system. But there are other things that also affect your immune system. And we try to keep the immune system as healthy as possible to make sure that it's able to help fight HIV. Obviously, HIV treatments are the best form of preserving your immune system. In particular, HIV treatments target the HIV virus, so they decrease what's called the HIV viral load. By having a lower HIV viral load, your innate immune system, in particular your CD4 cells, these are one of the most important part of your immune system, are able to increase in number. And by having higher CD4 cells means that people are less susceptible to other, what we call opportunistic infections. So it's definitely important to discuss the benefits of treatment with your doctor. There used to be limitations on the level of CD4 count that we could prescribe treatments. More recently, that restriction has been lifted, so we can now treat everybody living with HIV regardless of CD4 counts. So important to talk to your doctor about whether you would like to start HIV treatment. We also recommend vaccinations for things like hepatitis A and B. While these conditions don't necessarily cause acute liver failure, it's important that people don't become unwell while they're living with HIV and on treatment, as it may lead to issues with compliance of their medications. Other conditions such as pneumonia, a particular type of bacterial pneumonia known as pneumococcal pneumonia, can potentially affect people living with HIV more so than the HIV negative population. And we recommend a vaccination for this. Generally only one vaccination is required, as opposed to influenza vaccinations, which we recommend every year. Again, as I said, to make sure that you just don't get sick and have problems taking your medication. and some other viral illnesses may lead to an increase in your HIV viral load, and we don't want that to happen. More commonly, there's a vaccine for HPV or human papillomavirus. We generally recommend this in the younger population, but you can always discuss with your doctor whether or not this is something that may be applicable for you. There are certain cancers that are more common in people living with HIV, particularly cervical cancer and anal cancer. These are associated with HPV, so it may be one of the reasons why you may think about having a vaccination for HPV. Unfortunately, it is expensive, the HPV vaccine, so and not covered under Medicare, unfortunately, for the general population, but for the younger population it is. Lung cancer, and this is largely attributable to smoking, so again, another reason to try and stop smoking. Liver cancer, which is associated with hepatitis and alcohol. So how can you try to avoid developing some of these cancers? Unfortunately, some of them are genetic and we can't avoid them, but we hope that having a lower HIV viral load and a better immune function will help prevent some of these cancers. Stopping smoking, testing for hepatitis A, B and C, as I've mentioned previously, and vaccinations for these if negative. In terms of pap smears for women, we recommend an annual pap smear rather than every 2 years, which is what's recommended for the general population. So that may be why your doctor is recommending more frequent pap smears. In terms of screening for anal cancer, there's been some research more recently around the risks of HPV and anal cancer in HIV positive men, and there may be some guidance on what doctors should be doing in terms of screening for anal cancer. So in summary, the management of HIV, as you can see, focuses now on a range of other medical conditions, and it's never too early to take control of your health. And in fact, as doctors, we love it when people come in and want to be more proactive in their health. So hopefully you can have a good relationship with your doctor that manages your HIV. And if your current doctor isn't helping you with these issues, then maybe it's worthwhile to look for other doctors who may be a little bit more involved in these issues. And the Your Body Blueprint website has more information on the conditions that I've discussed, as well as some other conditions, and helpful links and tools that you may find useful. So thank you for your time and attention today, and I hope the presentation's been useful. And more information, as I said, can be found at the website that's on all of these slides, www.yourbodyblueprint.org.au. Thank you.